Hello and welcome to SmILE, the podcast where we talk about scientific developments and technological changes in Luxembourg and sometimes in Europe and sometimes in Europe and Luxembourg. And today is actually the case that we are doing an international episode, which means we'll be talking about a project that is crossing borders, but not too far away because we're in Germany and we're in Luxembourg. And to talk about the project today, we have two guests. We have Dr. Bernd Grimm, who leads the Human Motion Orthopedic Sports Medicine and Digital Methods research platform at the LIH, Luxembourg Institute of Health. And the platform aims to understand how human movement and physical activity serve as outcome measures, diagnostic biomarkers, and modality for treatment, prevention, or delay in many disease areas. That's very ambitious aims, by the way, Bernd, right?
Yes, I'm impressed how well you read it. Yeah, it's a long title.
It's a long thing, yes. Sometimes when you have to do it yourself, probably it's not so easy. And then we have also, joining from Germany, Professor Arndt-Peter Schulz, who works at Fraunhofer Institute and BG Clinic Hamburg. And he's an orthopedic surgeon and principal investigator of the consortium of the SmILE project we'll be mainly focusing on today. And Peter, thank you very much for coming, and Bernd, thank you as well.
Thank you very much, Hannah, to invite us here to join your famous and renowned podcast. It's a pleasure to be here, and I'm really grateful that we have this platform to distribute and disseminate our interesting project in Luxembourg and beyond. Thanks.
We start with thank yous. I have to thank you as well for the acronym, for the name, because I have to say that I deal with a lot of projects and some of them are very difficult to pronounce or understand. SmILE is perfect. Who came up with it?
Hannah, thank you. Yeah, that was us in Lübeck. We were thinking and we want something positive, because we see this as a positive project. And so smart implants for life enrichment, SmILE, seem to work very well. And it sounds good and we get positive reactions. There's only one drawback. Because of such a nice name, other projects have that in the past. So if you Google us, you find about 10 other SmILE projects.
Anyway, let's focus on SmILE. And it means we have to discuss two things first, I would say. And first of all, we are talking about the musculoskeletal diseases, so the musculoskeletal non-communicable diseases. What are the stats actually? How many people have to deal with it? It's a really big group of population that we're talking about, Arndt-Peter, right? That in the end have to deal with one of them.
Yes. It's actually, of all the non-communicable diseases, diseases of the musculoskeletal apparatus are the most frequent one. For example, it's the most often reason why people see their doctor in general terms, overall. There's a big of a difference. Our musculoskeletal area or diseases they significantly reduce quality of life, and they can push people into frailty in older age. But by itself, they don't have a high mortality, let's say. You don't die of hip arthritis, but every single step you make makes, life horrible. That's a big difference to other diseases where people have less, reduced quality of life, but have a much higher risk of an early mortality.
And what kind of diseases exactly? What are the most common diseases in that area, actually? We're talking osteoarthritis, right? They all have very difficult pronunciations, by the way. Osteoarthritis, rheumatoid arthritis, osteoporosis, of course. Different fractures and injuries as well go in there. What else?
Yeah, it depends a bit on what age group you look at. In the younger age groups, it's more the sprains and the fractures, and then coming up the osteoarthritis, gout, whatever you name it. And the higher age group you get into, it's more that osteoporosis really takes over, especially in female citizens. Coming with the osteoporosis is pain and also frailty or fragility fractures.
Low back pain as well, or not?
The whole back pain area is part of the musculoskeletal disease group. But again, back pain can have several causes. But mostly it's wear and tear, really.
I can add to this something which I think is very interesting, because although the musculoskeletal diseases are not directly related to mortality or don't cause mortality events, indirectly they may well do. And there's more and more evidence of that because of the loss of mobility and the pain that prevents mobility and starts very early on and changes the lifestyle. There is a lot of evidence that the reduction in physical activity, for instance, due to the pain and osteoarthritis, these may actually trigger all these secondary diseases that may then be lethal. So cardiovascular events, diabetes, even mental diseases. Colleagues of us, they will be running a symposium at the next World Orthopedic Research Congress that's named "No One Has Died of Osteoarthritis, but... ... and then it covers this aspect, and that should not be forgotten. And I think it's not only one of the most important reason to see the doctor, it's also health economically a very burdensome disease because it has one of the most lost days to work, so that people don't go to work.
So what's the reason that we don't talk more about it, or is it just my feeling that it's not so much discussed as other diseases? Am I right, Bernd?
Yeah.
What do you think?
Yes, I think you're totally right. There are maybe two reasons that I would see, and please, Arndt-Peter, jump in if I say something that's not correct. I think first, because they are not directly lethal, so you don't see this immediately. Although, for instance, also when it comes to frailty fractures, or fractures in the elderly people, when there is no fast remobilization after the fracture, there is a very high percentage of elderly people who pass away due to this lack of mobility, and they give up their living spirit, to say so. So I think it's not directly lethal, such as an oncological or cardiovascular event. That's why there's maybe not so much public awareness of it. And I think also that the practice of orthopedic surgery and orthopedic medicine in terms of research and innovation has maybe been a little bit behind some of the cardio and oncological developments. It's maybe a little bit self-critical perspective. And Peter, maybe you can comment on this.
No, yes, absolutely right. I think it's getting more and more into people's minds that's really the frailty caused by musculoskeletal diseases in the elderly that pushes them over the edge, and that is really an indirect cause for mortality and not a direct one. But we as researchers, we have to know that when it comes to diabetes or heart conditions or a stroke, that are the groups that often get the research funding rather than us, because, arthritis don't kill.
You said we as researchers, so now I want to go we as doctors, because you happen to be a doctor as well. I don't interview doctors very often. So what happens actually with the patients when they come to the doctor's appointment? What is offered to them right now for such diseases?
Yeah, that's a broad spectrum. But let's leave away all the young people with their ankle sprains and wrist fractures and so on. What normally happens if you have got a musculoskeletal condition, first line of treatments is also conservative, so meaning trying to avoid any operations and seeing if the problems can be solved or relieved, at least, let's say, via other measures like therapy, physiotherapy, and like medication, analgetics, lifestyle changes, weight loss, healthy nutrition. I think quite a bit of problems can be solved by that. Often, where it doesn't not work, in operation and some kind of the other is the solution. Sometimes a very good solution, like in hip arthroplasty or total knee arthroplasty. Sometimes not as, good as these procedures, especially in back pain. People get relief, but not as much as they really thought they would get from a procedure.
And then we're talking about also pain management, which is, again, a very difficult subject itself. But you used a buzzword that I was looking for. The buzzword was hip. And the buzzword hip leads us to the pub quiz question that Bernd prepared for us. So Bernd, can you ask the question, and listeners, remember, answer only at the end of the podcast.
The question is, why do people who receive an artificial hip or artificial knee implant live longer or have a higher life expectancy than those people who do not receive such an implant, or even the general population?
Very fascinating question. Remember, answer only at the end. Don't Google, as I always say. Don't fast forward to the end. Listen, because we continue discussing something that is really, really important, as we already said, and interesting as well. For me personally, I have back pain, as like a lot of people. Anyway, coming back. So we talked about the patient side a little bit, what is offered, what is possible. So of course, I wanted to talk about the wearable devices, right? So we're talking about monitoring people. So what is there right now? Let's say you want to check whether the patient is changing their lifestyle, or you want to check how they're living. What can you do with a wearable device nowadays?
Yeah, I think you phrased the question correct. The wearable is a tool to assess something. And I think in theory, it wouldn't even matter what tool you would want to use. But I think what's very important in terms of diagnosing early development of musculoskeletal disease or to rate objectively the severity of the condition, to aid clinical decision-making, or to observe if post-operatively the treatment is effective or needs to be adjusted, one needs to assess movement and mobility. And that is, of course, difficult to do if you only see the doctor very infrequently, or you don't have a gait laboratory like we have in Luxembourg, but that's an elaborate process that not every patient every time can undergo. So the need to investigate activity and mobility and functions, or how someone moves, is very important. It's often even one of the reasons why people are seeking intervention or support from the doctor, because they may not be able to play with their grandchildren anymore, or they cannot participate in sport, or they cannot do the gardening and so forth. So I think it's very important to objectively capture that. And the wearable sensors that have become available, let's say, over the last 20 years due to miniaturization, advances in battery technologies, and also in algorithms that can analyze the signals, they, for the first time, have offered us to screen patients in larger amounts and more frequently, and not only in a laboratory, but also maybe at the doctor's clinic, or even the free field at home. And that's where the wearable sensors come in, because they allow this kind of larger scale objective assessment of movement in the context of the disease that we want to investigate.
But we're not talking about the ones that I can buy in a normal shop, or yes?
In my perspective, there are two approaches. So you have these very dedicated medical grade devices, which have highly developed algorithms that perform an analysis of the signal after the measurement that can be very specific. I will include those. But I also see a role, and I think that will increase as technology advances, that you can use signals and information from the commercial devices that patients have themselves. That's also in the research community called bring your own device approach. At the moment, you are not able to harvest data of the same depth and detail that you may get from a medical grade device, but you can still harvest information about it. And these two disciplines are maybe approaching. So the medical grade devices become more affordable, more distributed, more easier to use. And the commercial devices that you can buy become more reliable, have more sensors, more capacity. So these are two disciplines moving together.
So we have the technology side, and we're going back to the medical side. So what kind of data actually, Arndt-Peter, would you be interested in when you want to know how the patient is moving on with the disease?
Yeah, that really depends on what we're talking about. In the SmILE project, we are primarily interested in data that is generated inside the human body. And so when we were talking about musculoskeletal diseases, it is data regarding motion, human motion, gait exploration. With artificial intelligence, you will be able to see many medical problems from the way people move, people walk, people stumble probably. So that is an area that we're really interested in. Also then when it comes to operations we performed in the past, let it be an artificial joint, or we mended a bone with a bone plate or a bone nail. And then it is very important to us to see how the condition of these devices is inside the human body. So is there any kind of interaction, let's say, via an infection, for example? So that is something we are really keen on to see. Does an infection around any kind of implant form, which is basically, we're talking about musculoskeletal devices, but the same applies to heart pacemakers or artificial vessels or whatever. Infection is something that we're really interested in. But also, is there any wear or tear, let's say, especially in the artificial joints is important to see, is everything working as expected? Because sometimes you've got a technical problem of an artificial joint, which increases the wear of it. Then it might get loose in the bone, which then, destroys the already diseased bone further. So it's really interesting to see these complications, which always happen in a certain percentage, but to see them as early as possible so that we as doctors can then act or react as early as possible to keep the damage to a minimum. So that are all areas that we're interested in. And with different sensors, we will be able to gain the information required.
Bernd, anything to add to that on the data side?
I think that this was a perfect connection, because we talked about wearables. And now we are talking in a way about implantables. So the sensor technology moves from on the body inside the body. And that's the real technological breakthrough, because you can then measure really where the motion happens. It has been the dream of people who measure human motion or put wearables to have actually the sensors in the bone, because that's where the movement really happens. Otherwise, you have skin effects, or you have the clothing above it. You need to position the sensor in a way. You need to calibrate the sensor. But once the sensing devices are in the implant, you have a much better representation of the movement. So these smart implants give us this aspect that we get much better data, and we can have continuous data, because there's no aspect anymore of patient adherence to putting on the device, putting it on the right direction, switching it on, charging it, and so forth. Everything is then in the implant. That's an advantage. And the data quality is much better this way. And then the next level of innovation is how Arndt-Peter already said, that of course we can then continuously monitor the rehabilitation phase, and then we can detect patterns that are maybe normal or abnormal in the rehabilitation and perform early intervention. So we will monitor aspects of movement throughout the rehabilitation phase. And then we can detect, for instance, so-called change points that may trigger an early intervention, or recognize patterns that are indicative of certain patients needing a specific adaptation of their therapy. Or what I recently learned, there are also rehabilitation pathways that represent a kind of a sudden gain. And then these subjects may not need any further attention, or not as frequent. So the health system, the doctors and the patients may save themselves unnecessary visits, and that can also be an advantage. So these are, I think, great opportunities in this technology.
Does it mean that people already are there with these implants in that monitor them?
That's a very good question. There are the first prototypes are emerging, and there's even one already FDA approved. So FDA is the US agency that approves medical devices. There's an FDA approved artificial knee that carries an inertial sensing unit in the part that goes into the lower leg, and they can measure steps taken per day, or they can calculate walking speed. And there are now the first data are coming out to monitor how people after receiving such an implant are recovering. And then a close colleague of mine, Dr. Benedict Braun from the University of Tübingen, he has just started implanting the first in human trials of a fracture plate that has so-called strain gauge. That's a sensoric device that measures how a fracture plate deforms. And through that, they can monitor how the fracture heals. Because when you put a fracture plate on a broken bone, the bone will hopefully start healing. And as the bone heals, the bone will take over the load from the plate. So at the beginning, that's the biomechanical theory. At the beginning, the fracture plate will take lots of the load. And as the bone heals, it will take less and less load. And this has been validated in animal trials in sheep, and now goes into human trials. And they are now the first in human data is just coming out verifying this concept. And I think this gives us hope that all the activities that we are in SmILE, that we can really generate a new generation of implants, and that actually may prevent patients from having unnecessary X-rays to monitor the healing process. That saves time, money, and also radiation.
Bernd, if I can add something to that, because it's a really interesting point. I mean, we have implanted these bone plates for fractures in about 65 patients in Hamburg in the past, and we know what kind of data we get out already. And the next step, we will, then make assumptions to how to read out this data, or maybe to how to make use of them. But that's exactly the point. So we've got the Americans with their first knee prosthesis. Professor Braun put in the first bone plate on with a chip that is actually a medical device with a CE mark. And I know in other areas, for example, in heart pacemakers, they can read out data as well. But the problem is, at the moment, is that all these manufacturers have got their own software, their own platform, and nobody else can read out the data. For us, it's really hindering success stories that way. So what we had as an idea for SmILE was that we want something that is universally readable. So if a patient from Luxembourg gets a smart implant and comes to a hospital in Hamburg or sees a doctor in Berlin or whatever, then it is possible to read out the data and, see what the problem is, because otherwise it's not really useful. It's only useful for the manufacturer of this specific device, and the patient is bound to them, really. So that was our basic idea initially as a start, learning from our own mistakes, because we used, a very closed system that nobody else could read out.
Yeah, that's a very good and important fact for many data-driven projects, I would say. The labeling, the less sexy part, the behind the scenes, right? When you actually put the data in such a form that other people can use it, not only those 5 insiders in the project, right?
There are 2 aspects that are important. I think the kind of device agnostic data collection that you can use across platform. And in SmILE, we have also set out to create a platform that can be used by other companies in the future to get onto, to not always reinvent a proprietary system to do this. Now, as Arndt-Peter says, that's really right, that we have these, let's say, islands that have their proprietary systems, and that may not lead to the breakthrough and the comparability. But if there is a platform, and here this could be a European platform, to standardize that. And then in this context, it's also the aim to generate a European musculoskeletal database that can be used to develop models through data science, AI, to predict these rehabilitation pathways and identify when intervention is necessary. And I think that makes our effort stand out from the individual commercial solutions that are developed maybe to lock in patients or doctors into a platform.
What I also noticed that is from the website and from your communication, that SmILE as such is not only this idea exactly of creating something that is sustainable and that lasts, but is also very patient-centered. So what's your approach to actually getting a buy-in from the people to have such implants? Because there is a bit of an ethical issue there too, right?
Both. There's A, we have to convince, and B, there's an ethical issue, or it's really one topic, isn't it? People are in general interested in what's going on inside their body. On the other hand, people are, or in the majority, let's say, a bit hesitant when it comes to sharing, their data with, let's say, everybody. So it's also a big part of the SmILE project is the health data governance, let's say. For us, what's really on top of everything else is the patient's consent to share the data, whichever, at every time point and with whatever they decide to. So it's, for us, the system doesn't stop when people get an implant, let's say, and they consent and sign a form and say that's okay. But into the daily use, all data will go via their, let's say, mobile device, mobile phone or whatever. And they can choose, at every time point, which data they keep for themselves and which data is better shared with a hospital, with their therapist, with their doctors. And it's a complex thing to build because people will have to get the information. The consequences of, for example, of not sharing information, if important, if it's, if the system thinks, there's, a health issue that should be taken care of, but still, nevertheless, the patient will be able to decide for themselves what they give away from themselves. And then on the other end is the, data governance, which in the EU, on the European level, has got 4 or 5 big topics. So all data governance is pretty much shaped by the general data protection regulations and other specific regulations related to health data. And there are some aspects really that, bring together the whole picture. It's the GDPR itself that provides a comprehensive framework for data protection on the whole of the EU. It has, changed Europe quite a bit in the last 10 years. And it mandates that all personal data, including health data, must be processed lawfully, transparently. That's very important. And for specific purposes, not just, with just sample data. So especially sensitive data, like all health data, has got special provisions and require for each time explicit consent for the processing. The other is the EU health data space. That's, a very interesting development of the European Union, which is creating this EHDS, European Health Data Space. That's right. To promote the use of health data for, all sorts of research, for policy making, and certainly for innovation. I mean, for innovation that, makes people healthier, but also creates jobs in the EU when we, are the leading edge of such technology. So there are other regulatory frameworks that are important in this context. You see, it's quite a framework we've got now running in the EU that is helpful on one hand because it, protects citizens and it helps researchers to steer in the right path, but also a bit complicated at times.
Oh, yeah. I am absolutely a European Union enthusiast, but regulation, it has good and bad sides. And what I see, it's possibly slowing down a project like yours with all the data sharing. And let's say you put an implant in and then the patient goes to a different country. I don't know am I right, Bernd?
Yeah, I think in general, I also agree that the existence of such regulations can give a framework to orientate on and improve the quality of research and also to protect the interest of the patient as a more vulnerable subject than all the experts that push technology forward. But on the other hand, it may also slow us down. And I think Arndt-Peter made a good mention that we have the tendency to look at the risks and always look at the possible negative effects. But there's also an effect of not doing these things and slowing them down. So I think it's also we have to find a balance of not preventing or delaying technological advances that can serve the patients. And I think your first question was referring to how to get the patients to buy into such developments. Yes. And I think this is a big topic in SmILE, and actually where we are most busy at this early stage, where we want to survey, interview, and also build a patient advisory board where patients have a co-creational input in everything that we do. And that includes how patients perceive the generation of data that comes out of their body that may be used for themselves, for their healthcare provider, or for research, and how to deal with that, how to make it useful for patients and for healthcare professionals as well. We are able to generate a lot of data, of course, to make it useful and actionable for patients or also for the healthcare professional. We have to maybe condense them into dashboard or numerics that are needed, and how to find that compromise. I think that's another very important aim of the SmILE project, to have an efficient way to present this information that it can be used in the clinic.
Of course, because looking also at how busy doctors nowadays are, how much time they have for each patient, I can't imagine them now sitting down with the data that is not prepared in some form that they can quickly interpret, right? Because there's just no way we can add more to already the busy plate, I would say, right, Arndt-Peter?
Yes, absolutely. That's one of our aims, to process the data in a way that is meaningful. So if you see the doctors or nurses or therapists in the hospitals running around nowadays, I've got a very, very tight schedule, and they just can't be bothered or don't have the time to start making calculations or whatever. They want the information they need presented in a manner that they understand them now. And that's really one of the aims of our project, to process all data in a meaningful way that is given a clear and fast overview.
One of the aims, there are a lot of aims. So I'll be definitely looking very, very closely at your project, because we didn't mention, but it started this year, right? So there's still a lot to do. And for sure, if you have some interesting outcomes, do share them with me so I can share it with the listeners. And just to finish off, I want to look at, because of course, SmILE project is not the only thing you're doing, both of you actually. So just to look at what you're doing except for that. So starting with you, Arndt-Peter, what else keeps you up at night at the Institute?
In the past, we have had a focus on developing better implants, which last more force, or that hold longer their weight, or whatever you want to call it. But more and more we're getting actually also in the Institute into a direction of robotics, in our field. Let it be the robotic surgical methods or robotic research methods, or robots that support human function. And what is coming up more and more, and I think will change our world anyway in a large way, is the whole area of artificial intelligence in whichever way you want to describe it. I mean, it's not the topic of today. We could probably talk 3 hours about that only for orthopedics, but that is what keeps us busy at the moment. And on the other hand, what we do from Fraunhofer, Lübeck, but together mostly with the trauma hospital in Hamburg, is clinical research. So translating our developments directly into the reality and measuring things like the performance of products or also the safety. So, risks occurring that, we have to be aware of, or that we have, that requires implants or methods to be changed. So that's also a large area.
So as you said, at least one more episode that is needed, if not two, to discuss all this. And now Bernd is going to add even more. So what else is going on? I've seen some other projects that you are also on, right?
Yeah, I don't know how much time I have, but I will start with some projects which I also have a connection to SmILE, I believe. For instance, we are currently engaged in one project that's called Next Step AI. And that's a collaborative project between the University of McGill in Canada, Montreal, and the LIH and the University of Luxembourg, co-funded by the Luxembourgish Funding Institute, the FNR, and the Quebec Research Institute. And here the goal is actually to use wearable sensor signals, and that can be translated also to the signals we would get from a smart implant, to detect context to walking, because nowadays we always look at step counts, but step counts, that's a contextless figure, and you can still be limping 10,000 steps a day. So you may fulfill some general health relevant threshold, but you're still functionally very limited, and you may just do it because you are forced to. But for the orthopedic practitioner or clinician to know whether a person uses or avoids certain walking contexts, for instance, stairs, cobblestones, walking up and down ramps or other surfaces, that gives much more context and is more meaningful for treatment intervention. So we have been using machine learning and deep learning methods to detect from existing wearable sensor signals if we can also detect the context of walking. And that is going very well. We still need probably 2 sensors in 2 different locations to have a satisfactory accuracy at the moment, but we are continuously developing this further, and that can maybe lead to generate meaningful metrics beyond just a step count. And I think that's one project we are engaged in. Another project that's if I have the time to answer, you can interrupt me, Hannah. It's because it's also nice and it fits also to SmILE. That's why I mention it. It's funded by the Oeuvre Foundation. That's a Luxembourgish foundation that also promotes physical activity and health. There is something when you develop osteoarthritis, hip or knee osteoarthritis, and you sense the pain. One of the common reactions of patients is to reduce physical activity, because they believe that the pain is a signal to become less active, and that's even a slow process, whereas in most situations that's not the right thing to do. So there is a lot of safe activity that can still be conducted, and that may delay the progression of osteoarthritis. So in this project, together with my colleague from the PASH group, Laurent Malissou, we have been developing an app where patients become educated about this situation, and where at the same time they can set daily step goals and try to achieve them, and we can measure those. So this is also such a concept we may also build into the SmILE platform.
Yes, exactly. And more. And as for those 2 projects, you mentioned who they are funded by. So I think we have to say that the SmILE project is funded by the European Union. The European Commission, right? Because we didn't mention that, and that's always important to put, somewhere in the brackets there, right? We know how it is with funding and grants and everything. So we mentioned that, we ticked the box, and the last box we have to tick is go back to the pub quiz question. Right. So I'll let you, Bernd, talk a little bit more because we have to solve it. So what was the question? Maybe if you can remind, because I guess some people don't remember the question anymore, and then the answer.
Yes. The question was, why do people who receive an artificial hip or knee implant have a higher life expectancy or a higher survival than those who do not receive an implant, or even the general population. Why is that the case? The answer is, or let me say, this was discovered in a huge registry study from the Nordic countries. So maybe as a context, in the Nordic countries, they have a long tradition of monitoring the survival of implants in patients who have received artificial hip or knee implants. And they found this out. And the reason for this is, as it often is, it's not a causal relationship. So there is a so-called well-being or well-patient effect. So those patients who receive such implants, they are already the ones who are relatively healthier than those who may not be considered for it. So if you are very sick, very obese, or have other contraindicating conditions, you may not receive this implant. This is one reason. But there's still also the reason that I mentioned first, that of course those people who receive the implant and are free of pain and can mobilize again, they have the health benefits of becoming active. So if our listeners or family members of our listeners are receiving such an implant, that's actually a good thing in many ways.
Really nicely wrapped. And on top of it, in a science podcast, talking about causation and everything else is also very, very welcome. So thank you for that question. Perfect. And what remains is to thank you very much for today, for telling us a lot about SmILE and other projects you're working on, and good luck with the project and good luck with everything you're doing. Thank you, Arndt-Peter. Thank you, Bernd.
Thank you, Hannah.
Yes, thank you, Hannah.
And this is it for today. Don't forget to subscribe, to follow us. We are on all the social media present. You can also suggest guests. Remember that this episode was proudly powered by Research Luxembourg, and we were recording at the Media Center of the University of Luxembourg. And my name is Hanna Siemaszko, and this was SciLux.